So it's a real pleasure to welcome Esmita to talk today. She's billed as an international speaker because her primary affiliation is still at Imperial College, but Esmita, as you may know, is an honorary associate professor in our division within the Department of Medicine at University of Cape Town. And she is also the research lead for practice design and engineering theme of the NIHR Health Protection Research Unit in Antimicrobial Resistance and Healthcare Associated Infection in Imperial College, London, and also holds a variety of other honorary posts, both in Kerala in India and in Bergen in Norway. And as most of you will know, Esmita has a long history, well, not very long because she's still very young, but I mean an impressive history in social sciences research around antimicrobial resistance, antimicrobial stewardship in particular, and really has done amazing works looking at hierarchies in particular, and really through Aspires as one of the lead investigators to look at the way people make decisions in infection management and antibiotic prescribing across surgical pathways. So it's a great pleasure to welcome Esmita to talk to us today on inequalities in global health and antimicrobial resistance research. Is this a design failure, a feature, or a system or a bug of the system or a bug? So Esmita, I've allowed for screen sharing, so you should be able to, and over to you.
Thank you so much. Hi, everyone. It's such a pleasure to be here and to give this presentation from Cape Town. Really delighted to be able to have had the opportunity to work with the team here for the last 4 weeks on carrying on from the work of Aspires, as Mark mentioned, and looking at the next steps, and particularly specifically looking at some of the issues that arose as we did the Aspires research and we understood the limitations of that work and what we were trying to do in different healthcare settings. So I'm going to talk today about the experience that we have had in global health and antimicrobial resistance research, particularly from the perspective of inequities, both in funding and also in inequities between populations, both in health-seeking and health-providing behaviors. Thank you very much, Mark, for that introduction. Why isn't this working? Sorry, just 1 second. There. So as an overview, I'm going to talk just a little bit about the research landscape in antimicrobial resistance and global health, particularly focusing on the evidence gap in equity in antimicrobial resistance research and the representation of high income versus low and middle income countries in global health, and how this led us down one of the avenues of research that we have been looking at, the narratives we try to build using imagery in global health and what that tells us about the biases in our work. And the struggles we've had with representation and research outputs and what we can do better in that field, and really lessons learned from the collaborations that we have had with colleagues around the world. And finally, just to summarize some recommendations that we're trying to make and ways that we want to work together with funders as well in global health research and to foster an environment of allyship that allows people to work more equitably together. So in terms of the inequities in the research landscape, we did a review recently with colleagues around the world, specifically looking at the research gaps in antimicrobial resistance in human populations, in optimizing antimicrobial use in human populations. And what we defined was there are inequities in funding, in availability of funding between the need for research and development for new antibiotics versus learning to optimize the use of existing antibiotics, which of course is paramount, because no matter how many new agents we get into the market, if we do not address the behavioral and the social and contextual issues around how we engage with infection and antibiotic use in different settings, we're going to have the same obstacles regardless of how many agents come to the market. But there's also a skew in terms of technology development in that there isn't much on implementation of technologies. There's quite a lot on development of new technologies, often without oversight of how these technologies are going to be fitting into different contextual environments, particularly in low and middle income countries. And close to my work and what I'm interested in is there is a lot of work that needs to be done around understanding the cultural and contextual drivers for how we use antibiotics and how we manage and treat infections in different settings, both from a healthcare provider, but also healthcare seeker perspective. And if we look at the geography of global health leadership, we see the gaps that really impact how we are able to secure funding, how we are able to work together. Whilst the majority of the global population is in low and middle income countries, this is not reflected in representation in global health research, where the majority continues to be in high income countries and the leadership continues to be from high income countries. And these are the challenges that we are facing. And I think that trickle down to how we work together and the challenges that we face when we are working together. So back in 2018, the World Health Organization started to ask these questions, specifically focusing on enhancing focus on gender and equity, trying to understand whether the impact of antimicrobial resistance is the same for everyone, whether any groups in society face greater or different risks of exposure to antimicrobial resistance, or challenges in accessing, providing and using and benefiting from the information and services related to AMR and infection prevention and control. But what we need to do really is to move on from considering each of these inequalities and their relationship with antimicrobial resistance as a unique interaction, and consider how all of these social constructs come together across axes of power and how they influence how we seek healthcare and how we provide healthcare. And the work that we have done, although we were never funded to specifically look at this, it has shed light on some of these issues that we are now wanting to take forward in work that we want to do together. When we look at the literature, specifically looking at the inequities in relation to gender, there's very little information out there, but the information that is out there does indicate there to be differences. Particularly, there was one study that looked at gender differences in antibiotic prescribing in the community setting, and this was a systematic review of all evidence out there by our friend and colleague Evelina Takaleni. And what they describe is that women are significantly more likely than men to be receiving antibiotics in the community setting, and they're 27% more likely to receive antibiotic prescriptions over their lifetimes. And they adjusted for the fact that urinary tract infections may be more common, and when they adjusted for this, there was actually no difference in the genders between male and female patients in receiving antibiotics commonly used to treat urinary tract infections. So the differences that we're seeing is outside of this particular condition. For respiratory tract infections, women were more likely to receive inappropriate prescribing. And then another study looked at gender concordance between the prescriber and patient. And this was in the Netherlands, looking at GP consultations in the community. And what they identified is that female GPs prescribe antibiotics less often than male GPs, especially in consultation with female patients. And so the gender interactions that influence prescribing of antibiotics are overriding the policies and guidelines that we put in place to streamline how we treat infections in the community. There is very little evidence from different healthcare economies. The majority of this sort of evidence that is available is from high income settings. But the work that we have been doing in the last 5 years in India and in South Africa, and through my PhD work in the UK, is really what led us to want to look at this more closely, because of the power dynamics that we were observing in the qualitative research that we were doing in hospital setting, both from the challenges that healthcare providers faced, from different gender and ethnicities, but also as patient populations. So in the work that we've done in surgical populations in India and South Africa, we've described that within families and society and clinical teams, gender dynamics and power dynamics influence how women seek and provide infection-related care. And it also has an influence on leadership patterns that we are seeing. And there's a lot of lessons we can learn, for example, from female leadership in surgery, and how that can lead to better engagement or better communication and task-driven activities in ward rounds, which was very fascinating for us, even though it wasn't the fundamental question we were asking in our research study at the time. And then in India, we very clearly saw through the research that we were conducting how women are often left out of health-seeking opportunities. So there was this one particular case that I remember, was a man who'd come in for a routine hernia operation, and his wife was with him. And just because she had attended as a carer, they decided to also look at her and do a health checkup for her. And in fact, it was her who needed to have emergency surgery for a cabbage, because she was in much worse shape than her husband. So we need to look at how in different cultures and communities we are creating missed opportunities for equitable access to healthcare between people, whether it's by gender or socioeconomic condition or race or ethnicity. And one quote that stood out for me was this particular lady in India who we interviewed as part of our research, who very proudly told us that she's had 3 children, but she's never stepped into a hospital because for her, being ill and needing hospital care was associated with social stigma, and she felt it was, you know, a sort of badge of honor to never have needed to seek healthcare, even though she had given birth 3 times. So it's these cultures that we need to understand better in terms of health seeking and health providing behaviors. And going back, way back to my PhD, I conducted my PhD at Imperial College in London at St Mary's Hospital, where it's a very socioculturally diverse population that we serve. We have a huge migrant population there. And I often, because I speak different languages, I'm originally from Iran, but I also speak other languages in the region, I would offer to translate for the patients if they struggled. And I came across so many challenges that migrant populations have in accessing healthcare, in being environmentally and socially aware of what is their right in terms of the healthcare that they are able to access. And one particular case that stood out for me was this lady who I translated for. She was from Afghanistan, and she was seen by an all-male surgical team who went through all her symptoms and decided that she needed to have her appendix taken out and were about to send it to theater. And she nudged me back to her, beckoned me to herself after the team had left and said, actually, I'm embarrassed to tell the team my symptoms because they're all men. And what she had was pelvic inflammatory disease. All her symptoms were vaginal, and she was embarrassed to say this to the all-male team. So then I went back to the surgical team and said, I think you need a female gynecologist to come and speak to this lady. She doesn't need her appendix taken out, but she does need antibiotics for pelvic inflammatory disease. So these are the issues that through our existing research has really piqued our interest. And when we looked at the literature, we realized there's so little out there, and how we need to really look at how we can provide equitable care to the different vulnerable populations within our healthcare systems. And recently, during COVID-19, I've been volunteering as a vaccinator, both in the hospital and in the community setting, in very different socio-demographic parts of London. And one of the recurring questions that we had from our minority ethnic background healthcare workers in the hospital was the lack of trust in the government, the lack of trust in policy around public health responses to the pandemic, which shaped whether they would take up vaccination or not. And I had one ward clerk who was from the Caribbean who told me she doesn't trust the government because of how this current government has treated her kind in the past, her ethnic minority group in the past. So she mentioned to me the Windrush generation, which was, we had a huge scandal in the UK where second generation Caribbean citizens of the UK who hadn't got their paperwork in order were deported. A proportion of them were deported, very summarily deported from the UK, which led to huge consequences for them to go back to a country where they had no affiliation with. They'd lived all their lives in the UK, and some of them did very poorly in terms of health outcomes back in the Caribbean. So if we are going to want people to behave according to public health measures that we implicate, I think it's really important for us to understand how we build trust. And another example is the radioactive chapatis, which was an MRC study in the 1950s with Punjabi women in the UK, where because of a high level of anemia detected in Punjabi women population, the MRC authorized a study where these women were given radioactive chapatis that were ready made for them, laced with radioactive salt, without getting consent from the woman, and then their iron levels were traced in specific facilities. And this was a huge scandal at the time, but it's an indication of how you need to develop trust over time. And if we see different subpopulations within a country or within our healthcare cohort being wary of public health interventions, I think it's really important to dig deep and understand what the history is behind it, because a lot of our behaviors, particularly in the socio-medical field, are very closely connected to the histories of people and populations. And particularly in terms of gender inequities, it's really important within the healthcare workforce to understand that 67% of the healthcare workforce is female. Occupational segregation by gender is a persisting problem. The majority of nurses are female. And globally, we've done surveys twice. We've done surveys across 5 years with individuals who are involved in stewardship interventions. In the first survey, it was across 52 countries. In the second survey we did last year, it was across 72 countries. And the workforce, one of the key obstacles that keeps coming back to us is how little pharmacists and nurses are engaged in stewardship activities and interventions. So it's very important to understand this and understand how this is linked to the background of the healthcare professional workforce we work with. Candice Bonaconsa and Oluchi Mobawalu, who are our postdoctoral and research nurse, postdoctoral pharmacists and research nurse who work with us at UCT, did a really nice study, led on this study looking at communication on ward rounds within surgical teams here at UCT, and we described the flow and the sort of the traffic of communication on ward rounds. And this little gray bar is how much nurses and patients were involved in the discourse around patient care on ward rounds. And when you consider how much information the nurses actually have about the patient, this is a critical gap, which we've actually now working with Professor Ivan Joubert in ICU with who's really taken this on board and transformed the way they do ward rounds, which is really fantastic to see how qualitative research has been able to shape behaviors here in UCT. But one of the shortcomings of the work that we did was, and it was raised to us very early on from colleagues here at UCT, was that you cannot do this research without looking at race in South Africa, or for that matter, caste in India, because this study was across South Africa and India. And at the time, we didn't have the ethical approval to do this study. And to look at these other socio-cultural constructs which influence health seeking and health providing behaviors. And this is something that we want to come back to and study in more detail, having got this firm ground understanding of how the teams are operating in the hospital here and how the teams that we have worked with. And for this kind of research, to better understand the human and social dimensions of AMR, intersectional approach and framework is one framework that is being used more so in high-income countries, less so in low and middle-income countries, but is something that we want to use to investigate the role that social constructs such as gender, class, race, and caste have, and how these interact with other factors, for example, residency or migrant status of individuals, their positionality within their society, within their families, and how much these factors give them accountability and agency to speak up for themselves, but also to be able to be participants in care, both as healthcare providers and as healthcare users. So the question we want to ask is, how does power manifest itself across these social constructs? And what does that mean for antimicrobial stewardship and infection prevention and control? We wrote about this in terms of AMR, and we have a student now in the UK who is looking at this from the perspective of the role of intersectionality and how it interacts with AMR and IPC-related behaviors in migrant populations in the UK. But there are many questions that we need to ask about how power relations and hierarchies across these constructs affect infection-related care seeking and providing behaviors, and what interventions are needed to address these differential healthcare user and provider behaviors in relation to antibiotic use and antimicrobial resistance. And of course, I think we all have to be acknowledge that, in different countries, we're working in very different sociocultural challenges, and South Africa has its own challenges. And particularly during COVID-19, the intersectional research that has emerged, and in fact, there's been a lot of light shed on this during COVID-19 because of the disparities that have come to the fore and have been exacerbated, particularly around the gendered impact of the pandemic, that although more men are likely to die or were likely to die early on in the pandemic from the infection itself, the long-term consequences of the pandemic on women in terms of loss of earnings, in terms of having to look after family members and becoming primary carers has been much more prolonged and pronounced. In South Africa, there was a lot of news and articles about the military deployment used to control or to enforce lockdown restrictions. And I think the United Nations did a study in South Africa, Kenya, and Nigeria were three of the most restrictive in terms of how they enforce the lockdown measures. And this, of course, was more in the townships and in the city areas where people of lower socioeconomic denominations live, and the inequity in that, and of course then the deaths of Nathaniel Julius and the death of Collins Khosa, which led to the riots and uprising that we saw. And in the UK, we had similar with the George Floyd death, and the riots happened, not the riots, the protests for the Black Lives Matters movement happened in the UK. And I remember it was during the first lockdown, but the enforcement and how it mobilized a part of the socioeconomic factor within society which has often been neglected and whose rights have been neglected, and also who are probably at most under threat from the negative consequences of the pandemic. In India, the migrant workforce was one of the most affected because a lot of the people from the villages were working in the cities and they had to go back to their villages, and the direct observed therapy for TB was disrupted. And of course, in the UK, we had Partygate, and there was a classist, if you like, response and ability to manage oneself through the pandemic. So we had, a lot of the people were observing the rules, but as we have seen since, our politicians were not, and there's a lot of corruption, cronyism. So no matter where we are in the world, inequities did make it impossible for us to be able to adhere to social distancing and infection prevention and control measures, or the classism that we saw was driving flagrant disregard. And this has been persisting as well with the vaccine inequity that we are seeing currently around the world in terms of access to the vaccines. So coming back just to South Africa, of course, the gender health gap is also triggered by socioeconomic inequities, which deter economic growth. And there was a report this month that was published, which highlighted that South Africa has one of the greatest, or the greatest, inequity within its society in terms of socioeconomic inequities. And a lot of these are inherited circumstances over which, as individuals, people have very little power. And there's a great sort of a short anthology of essays that has been written about this by the Center for, I have to get this correct, Center for Sexualities, AIDS and Gender in University of Pretoria by Professor Rebecca Hoda's team. And they have highlighted how situating women from low and middle income countries to a Western hegemony and constructing women in global South as exotic, non-agentic and passive victimized has impact on not only the outcomes of the pandemic, but the longer term impact of how they seek and provide care. And this is something that particularly we had firsthand experience working with the WHO recently, which led to us to look at the imagery within global health and how the biases we carry into the work that we do. So we were invited in the European Society for Clinical Microbiology and Infectious Diseases. We were approached by PU Afro to do a set of slides for behavior change and antimicrobial stewardship for West Africa. And they had only approached our colleagues in Europe. And one of the first questions I asked is, why haven't they gone to your African collaborators? There are so many people on this talk that would be absolutely perfect to give the talk. And the feedback from WHO was that no, we want this to be across continents and therefore we want European audience. So I managed to get Winnie Nambatia from Uganda to do the talk with me. And then they took our slides from us and said, we need to brand this using our WHO branding on your slides. And I was quite shocked when we got the slides back, and I don't know if you can imagine what you would use as an image to talk about behavior change and antimicrobial stewardship, considering this is a predominantly European faculty speaking to an African audience. And these are the slides that the WHO had finally chosen. And I didn't even know what this picture depicts until I came here and I spoke to my colleagues who told me this is a group of women going to church. The candles they carry is the candles that they carry to church. So absolutely no relevance to AMR or IPC. And in fact, I would be surprised if WHO Europe would produce something similar with a group of nuns going to church in Europe to talk about AMR. So we got together with, I presented this to a group of students that I was teaching on a BSc in global health at Imperial, and we had a conversation about this, about how the power of imagery and how the narratives that we choose to depict through images are a window into the biases that we bring into our work. And so the team, we got together with Winnie in Uganda, Oluchi here in UCT, and Alex, Samid, and Rabia are the medical students. So we decided to look at the use of imagery in global health. And the reason we decided to do this is because when we pushed the WHO that this is an appropriate image, they pushed back and said this is their corporate imaging and they're not going to change it. Luckily, our names were not on the slides. I would have been mortified if I was associated with those slides. But we looked at, we reviewed 100 reports on AMR, infection prevention and control, global health and vaccination between 2015 and 2022, specifically looking at the use of imagery and what the imagery has in terms of relevance to the subjects being discussed, the integrity of the subjects that have been depicted, whether consent was sought from those whose images were being used, and the representation, whether the images were accurately representing the reality of what was being photographed, and whether there was an imbalance in demographics of those represented. And it's really eye-opening exercise for us, because what we identified is issues in relevance, integrity, consent, and representation across high and middle income country and low and middle income, high income country and low and middle income countries, depending on what the publication report, what the target audience was. There is a lot of staging and digital manipulation when images are used of Western or high income setting participants. For example, a lot of these images, as you can see clearly, are actors. And this has huge implications for biased representations, from misleading, irrelevant disease association, and in terms of just public perceptions of what it is to be working in global health as a global health community. Additionally, we looked at how images of children were used, and 40% of the documents we looked at had images of children, of which 90% were images of children of non-white ethnicity. And a lot of images, 71%, contained an image of a photograph of a child on the cover, often with no relevance to the subject that is being discussed. When images were used from low and middle income settings, often they were candid images, there was no consent, and people and subjects were often not aware that images were being taken. So it goes back to what I was saying earlier about the history that interconnects people and power differentials between people in different settings. And the visual framing of global health and AMR is very skewed at the moment, and it really speaks to colonialism and othering of diseases. And for us, it also reflects the policy agendas and interests of different actors in dealing with global health. And it's something that I think it's worth highlighting, and also being able to challenge going forward, because it is a continuum of the narrative that we are writing in AMR and infection-related global health research. And that representation carries, this inequity then carries on into outputs. So this is a map of 2016, I think, of research outputs by region of the world. And as you can see, the majority of the research outputs in health continue to be from high income countries, despite the majority of the burden of disease and challenges we face in global health are in low and middle income countries. And this is something that we need to challenge. I'm very happy that increasingly this is being recognized. There is a consensus statement that was written on measures to promote equitable authorship on publications of research from international partnerships, particularly international partnerships. And I'll come to that, because there is already a skew in how we work in international partnerships because of the way we are funded. But Saya Abimbola, who's the editor of BMJ Global Health, is very vocal on this, and he has led this work in many different media formats. And really what it is about, the problem begins with donor funding and with the skew in high income country research capacity and the access that they have to capital versus the access that we have capital, or there is access to capital in low and middle income countries, and a lack of understanding of the community, clinical and policy context that drives research. So in our work with Aspires, we consciously tried to be different and work differently. And I'm really pleased that the early career researchers, both in India and South Africa, were able to be first author on papers. We gave them the freedom and the space to do that, to learn as part of the process, but also that those who wanted or who were at the right time in their careers were able to register for PhD studentships. Candice is doing her PhD here, working with some of you. Brenda in India, who's a pharmacist, started a PhD. Aluchi's got a postdoctoral fellowship. This is really important, because the reverse is, I also benefited hugely from this collaboration, and so did my colleagues in the UK. I was awarded a Hamid Foundation UK India AMR visiting professorship, which I wouldn't have had if it wasn't for the Aspire study. So being affiliated with a low and middle income setting for an academics who work in high income settings opens opens many doors, and that has to be bi-directional. We have to work in a way, in an environment which means that these opportunities work in both ways. And these other three researchers that we have, Fabia, Pranav, and Surya, they're a bit earlier in their stage of their careers, but they're also actively looking, and we're supporting them to be able to achieve their ambitions in academia and make sure that they also deliver to what they want. And the reason we were able to do this is, from the beginning, we adhered to a strict set of conditions, if you like, to make sure that we had equitable partnerships. We had effective leadership through Mark and Alison Holmes in London and Sanjeev Singh, but also through the qualitative research that we gathered, which was very immersive and working very closely with the teams within each country. We were able to develop a program of training and respecting the equity in resource allocation and funding, and providing mentorship to make sure that we were able to support our team. This is really important because what we were able to do to some extent was we were enabled to do because of the funding structures that we have. So as much as the funding is amazing, it can also restrict what we can do in partnerships. And that's why we need to engage with funders as part of this dialogue on equity. Globally, this is before the pandemic, of course. And what they found is that the majority of this funding is not correlated with the burden, the level of burden of disease and the risk posed by infections. A lot of it is driven by the needs of high-income countries and not the needs of low and middle-income countries. And this other paper, which was looking at why global health needs are unmet by research efforts, this is a very powerful chart for me, where they tried to measure the DALYs for infectious diseases so the burden of disease by publication, by population in different countries. As you can see, high-income countries have one of the least burden, but carry the most in terms of outputs in research publications. And that's something that we need to address and collectively be able to, as researchers and collaborators, work together to challenge. And the funder inflexibilities are paramount and really important in this, because there continues to be a limited participation of low and middle income country expertise in funding panels. This is something that I've seen firsthand with many funding panels that I work with, but equally something that has been raised by others at far further ahead in their research careers than I have been, and much more vocal than I have been. And what this leads to, if we don't have representation, we end up with arbitrary choice of intervention from research topics, and there's little engagement locally. And this is the problem, because what happens then, a lot of the funding and resources remain in high income settings, which means we end up with the challenges that we have had. So what we need is to work for greater representation at the funding level, and not just trickle down at the collaborator level when we are trying to work together. It's almost too late by that stage already. We need to work much more high upstream to be able to change these challenges. Professor Madhu Pai at McGill University is very vocal about this, and I really like the slide he uses, which summarizes where global health grants go. The majority of the Wellcome Trust, USAID, and NIH funding and Bill and Melinda Gates remain in high-income countries, even though they're targeting global health research in low and middle income countries. So what we need to do is work with funders to help them understand how we can develop more equitable global health research opportunities, but also address the imbalances in power and the resource imbalances between high income and low and middle income countries. And relative to need, of course, there needs to be more involvement from low and middle income countries and more investment from low and middle income countries in research capacity, but that is linked to historically socio-political factors which have influenced how these many countries are being have access to funds. So that alone should not be a reason why high-income countries shouldn't divest some of their funds more equitably. So the work we're doing now with editors at BMJ Global Health and Plus Global and Public Health and colleagues, and Mark Ramanan Lakshminarayan from One Health from CDEP, is to look at this and try to come up with a solution, or at least start a conversation with funders about each stage of the funding, how we can revisit and reimagine how we can collaborate and develop opportunities for global health funding and collaborations that are equitable, but also that make sure that there is sustainability in the opportunities that are available, so that often what happens is once the funding stream is finished, all the resources are withdrawn. But what we want is a mechanism where the resources remain within low and middle income countries, so that if they are not bound so closely to the funding that is available. And having discussed this with colleagues here, including with Professor Delamini, Sipo Delamini, and I was really grateful to him for highlighting to me the work of Professor El Alwani here at UCT, who's looked at occupational consciousness. And this is something that she has written about within occupational health, that it has huge implications for the work that we're doing in global health. And what she describes in her work in occupational consciousness is about an ongoing awareness of the dynamics of power and recognizing that dominant practices are sustained through what we do every day. And for me, this was an eye-opener, and I've read this a few times, and I really recommend everyone to read it, because it's really a new way to look at how we can identify how power manifests itself along economic, racial, ethnic, and gender and cultural boundaries in health systems, and how that impacts specifically infection prevention, control, and antibiotic use behaviors. And this understanding will help us be able to leverage the strengths of different groups. For example, what nurses can bring to antimicrobial stewardship, or what female leadership in surgery has to offer, and how we can learn from that, rather than just focus on the negatives. I always talk about academic allyship, because to me, that's the sort of foundation of everything I try to do. But it was very heartening to see Professor Pai this week in Forbes write about allyship in global health. And this is really important, because global health, as according to the article that he has written, is firmly centered still on those with power and privilege. And is really, we are reliant on the generosity and saviorism of a group of individuals. And what we need is an awareness of the power differences between individuals and groups in order to be able to go to the next step and develop seed space, share the platform, and give up the seat every now and then to make sure that there is equitable representation. Power is very difficult to give up, but it is something that we need to train. I think leadership in academia and in global health needs to have this incorporated in how do we share power in global health, and how can we work better together. So for me, that links into academic allyship, because I've had to learn to share the platform I have with the early career researchers I work with. And it's actually much more rewarding, because you have more outputs when you have more people to work with. I don't understand what the problem people have with sharing the platform, because it gives you more power, not less. And some discourse has also happened about moving on from academic or global health allyship. We have to talk about co-conspiration. So it's about actively trying to change behaviors and building trust and solidarity and commitment in global health to make sure that we can work together more equitably. So in terms of next steps and what we want to do, having learned from the lessons and the gaps in our research so far on the Aspires project, we want to come back and look at the sociocultural and contextual drivers, including gender, race, and class, and how these influence health-seeking and health-providing behaviors in IPC and AMR, specifically in understanding how existing structures and systems are excluding or disempowering specific parts of the population or healthcare worker population, and to provide solutions that dismantle these systems so that we can work much more cohesively together. And working with the hypothesis that sociocultural and contextual drivers, including gender, race, class, influence health-seeking and health-providing behaviors. This is the foundation from which we want to be able to develop more inclusive interventions that leverage the power that exists within different populations, including patients and carers. We have fascinating data from India on the role of carers in health, in infection-related care, which I don't have time to go into, but hopefully we'll be writing about it soon. It was very interesting for us to see, as we were writing this grant, ICARS, the International Center for Antimicrobial Resistance Solutions, had put out a call specifically looking at the role of gender equality, strengthening gender equality and social inclusion in low and middle income countries, and in relation to antimicrobial resistance. And we worked with CDEP, and Mark keeps telling me they've just changed their name and I can't remember their new name, One Health Collaborative or One Health Drive. Mark will tell us after I stop talking. But so CDEP and whatever they're called now, we worked closely with them, and we wrote a grant specifically looking at the gender inequities within structures, including in families and healthcare, and how that impacts health-seeking behaviors. Because we don't have this knowledge, we need to understand this. We need to gather this data to understand how we can better engage with stakeholders that need to be engaged, and also how the pandemic in the long term is going to impact these behaviors. So I just very quickly, I'm going to put myself in this picture, because obviously I'm not from South Africa or India, I'm from Iran. And although I haven't experience the kinds of oppression that have been experienced in South Africa. I was born in the year of the revolution. So before the revolution, women in Iran had rights, same as here, same as in any Western country. And then lucky for me, or unlucky, as I was growing up, the Iran-Iraq war happened. So I had a very troubled childhood in terms of war and mayhem and being a refugee. But it also, experiencing life as a refugee in different countries always made me an outsider. And I have experienced healthcare and society from the perspective of a refugee, and being a translator for my parents. And I think that's why it's very close to my heart. Whenever I have an opportunity, I translate for other people in healthcare, and seeing the difference it makes when you can speak English properly to the care that you get. It's incredible. If you can speak the language properly, the care that you get versus if you can't. And the reason I put this slide up is because in terms of this power struggle for women in Iran, after the revolution, there was a huge backward trend in Iran for women's rights, and this impacted their health and also their contribution to society. And this photo is very early on in the revolution. She's a very famous actress arguing with a cleric about women's right to choose what to wear. And of course, over many years of repression, women in Iran are currently going through another set of disruptiveness against existing structures and hierarchies. So the White Wednesdays movement is now seeing Iranian women take off their headscarves publicly, and a lot of them are getting arrested or harassed for this. But the struggles that women have in different societies, firsthand, I have seen how this impacts health, including health and health-seeking and health-providing behaviors. And for me, that is the angle. It's very important for me to do this research, because regardless of the cultures we live in, the rights of women are always trampled upon and compromised. And I'm just going to finish with this slide, because in academia too, as a pharmacist, I've always been told that I'm a square peg in a round box, I think, wherever in society as a refugee or in academia as a pharmacist. But, I think you can use this to your advantage. And this speaks to what Elwani was talking about, occupational consciousness, is sometimes your disadvantage can be your power, and you can make change by being an outsider. And it's never about fighting individuals, that is about fighting or challenging systems that are sustainable, inequitable structures that we need to address in healthcare, particularly in global health. I'm going to stop speaking there. I have a lot of people to thank. And I would love to have a conversation around this. I think we have 15 minutes. Thank you very much.
Thank you very much, Esmita, for a really wonderful talk, and highlighting very real issues that facing global health, and obviously AMR, our own field, but way beyond that. And COVID, as you say, again, has taught us a variety of issues around this. While colleagues are thinking their questions, and please, if you could use your hand, if you could just pop your hand up on the participants who'd like to say something. I mean, Esmita, there's so many things to talk about there, but I was interested in just your thoughts on this observation of prescribing differences between female and male surgeons, and why you think there is this difference, and whether in your work across the high-income countries setting in the UK, whether that was your experience as well, and do you think there are different reasons, or what's behind it?
So the ethnography work that we did in the UK in surgical and medical wards, we did notice differences in the leadership style of male versus female consultants, and we saw the same here in South Africa. And interestingly, we didn't have any female consultants other than a female anesthesiology consultant in India, so we weren't able to look at this. But I wasn't collecting data, although I was collecting data on antibiotic prescribing, I wasn't collecting it by gender of the prescriber or gender of the patient. So I don't know, Mark. I don't know what this difference is, but I think it comes back to, which is why it's so important to do the sociocultural research and the behavioral research, is how we behave socially, and how that so much of it is related not to whether we have all studied medicine or pharmacy or a specific specialty, but what we bring of ourselves to the work we do. So I wonder whether for female, and it's female women to women versus women to men, isn't it? So men are more likely to prescribe antibiotics or medicines to women. I wonder if it's something about women being better listeners and having more time to consult with the patient and understand what is really wrong with the patient, versus men may work in a different way, male prescribers, and want to just get through and go to the next patient and be more protocolized, you know, and that I have seen in personal experience too, how good a listener you are as a physician can decide what the quality of the interaction and the quality of the outcome you have with the patient.
I was just, as you said, I was just listening extra hard because that's obviously, I'm joking. Sorry. Enrique, I'm not sure if we put Enrique on the spot. Enrique, I was wondering as well, you know, I mean, nurse Esmita, and you know this because of your involvement in Inspires and this whole issue about nurses and pharmacists, but nurses in particular being left out of decisions. And does gender also come into that within nursing? I mean, as a male nurse, have you any experience of that?
Hi, well, thank you, Esmita. Absolutely fantastic. I suppose in nursing you have got that weird paradox where majority of the profession universally is female, but the decision makers and sort of the policy makers within the profession are universally male, and we've got this weird situation where males are sort of shaping a female profession. But I completely see the issues with leadership and sort of the testosterone excess that we've got in many of negotiations and diplomacy within the professions and between the professions. That's certainly we've seen that in nursing.
Thanks very much. Okay, good to see you. Sipo, I wonder if you'd like to make comment, because you've been in discussion with Esmita and, as she said, provided some material. I'd be interested to know your thoughts.
Yeah, no, thanks, Mark, and excellent talk by Esmita. I think this issue, and I'll speak about occupational consciousness, because I think it clearly, as a construct, is what the kind of work Esmita is trying to do, help give us a language to use to break down these power barriers. So your question to Esmita about why females would behave differently compared to males. I think that the females may be occupationally conscious and are disrupting the field. So that's what happens when you become conscious about the power dynamics that are happening. Because remember, what we're trying to do here is to disrupt how we do things every day. It's the everyday doing of things. And if you're going to bring behavior change in relation to either infection control or antimicrobial prescribing, you have to change the behavior. Now, for that to happen effectively, people have to be conscious about what is happening around them. So I think, certainly, I think there's an element of females probably having gone through a system which is male-dominated with other isms, are consciously aware in the occupations they hold that there are power dynamics at play, and how then they use their position to disrupt the occupation. Because that is what is happening. It's a disruption. And I think sometimes as males, we probably don't see the disruption when it's happening in front of you, because I think there's a lot of disruption happening and we're not really aware of it. And I think that's the other thing, is to get people to begin to be conscious about these things and have a language to use to identify many of these challenges that we're experiencing. So yeah, so that's my 2 cents. I don't know what others think.
No, that's great. I'm going to actually hand it back to Esmita to make comment on any of either your and Enrique's before going to Tari and Lucas, who would like to make a comment, question.
Thank you. I just left a message, but it went straight to Jackie Hoare. Sorry, Jackie, that was for all of us, not just for you. I made a comment on what Sipo said, because I think you're absolutely right, Sipo. And I always think about this, but I think, and I have conversations with my friends and colleagues who are male, there is a pyramid, and men are on top of that pyramid in terms of power dynamics. And you don't have to be, you are not forced. Because the system works so much more for you than it does for women. You don't have women are made to and are forced to, if you like, are driven to be more occupationally conscious than men are. So you'd have, and I think that is one of the sort of imbalances, that natural imbalances that is there in society, in hierarchies, not just in healthcare, everywhere, which is why women are more occupationally conscious. So I agree with that. But it's how, in terms of the nursing, we have data from what Candice and Lucia have done, that even when nurses position themselves, they're already signaling on a ward round how much they're going to be involved. So they are so, there's this social awareness, this pecking order is visible, you can see it. It's not even something that is just, you know, power imbalances in the air. Or, so that this is something that I don't know, in the data we have, we never looked at by gender. I keep looking over there because Lucia and Candice are sitting there, but we didn't have at the time, because we didn't have the remit to look at race or gender. We don't have that data. We only have data on the leadership on the ward rounds, whether it was male or female, but the gender division in nursing and how that impacts behaviors would also be really interesting to look at, Enrique, I think.
Great. Okay. Tari, and I don't know if it's Tari or Lucas, but the twins are there. And then I think Jackie, we're going to make a comment as well. So over to you, Lucas.
Thank you. Thanks, Esmita, for a great talk. We were just asking, this is very relevant for Tari and me as two males. Usually in science, you know, like a gender or sex is a very like unmodifiable risk factor, or at least quite unmodifiable. And I think this sort of ties into what you've already been talking about, but is there any evidence on that maybe in this social structural context, it's maybe more modifiable? For instance, a man taught by a female professor, you know, do they display the same behavior? You know, is there any way we can modify this sort of gender difference that exists in terms of quality of healthcare provision?
I think there's opportunity to look at that, definitely. And, you know, statistically, there are now more female medical students than male, right? So I think over time, this is shifting anyway. But what we definitely observed is, you know, the leadership. There is so much to learn from the leadership style of female consultants that is not being tapped into, because I don't think they're even aware of these differences. But there is a lot that can be harnessed from how we occupy the space in healthcare, like Sipo and the one you talk about, this occupational consciousness is how we bring ourselves to the work we do, and how that needs to be studied, and we need to learn. It's not about pointing out that men are worse or women are better. It's how can we leverage the strengths of each, whether it's nurses or pharmacists or male consultants or female consultants. But there is a lot in cooperation and building on the strengths. But that, I think, needs time. And I don't know, Candice and Lucia, do you want to say anything on this?
If you do, can you say it? Or maybe while you're waiting to say it, while if you're thinking of it, if you could just raise your hand if you want to. But Jackie, your thoughts?
Hi, Esmita, thanks. It was really awesome. So just picking up on what you and Sipo were talking about, I think the only way that change can really happen is for us to become comfortable with having really difficult conversations. Because I think the kind of change that you're talking about is not really possible unless we have the courage to have really difficult conversations. So, and I think that that's an incredibly important thing that we should start modeling, because I certainly don't think that male clinicians prescribing females more antibiotics is as simple as women are willing to listen to their patients better. I think it's probably a lot more complicated than that. But I think for men to be aware of that, how they see women requires the ability to have really difficult conversations. I mean, we call it the pedagogy of discomfort. And it really is about learning to sit with discomfort and being courageous enough to actually say it out loud. So I think it would be really amazing to do some qualitative work around this. But again, it's probably, it'll only be as good as the conversation that people are willing to have. Yeah. Thanks.
Thank you,
Thanks
Jackie.
again.
That's a really important point. Absolutely.
So we have to ensure that the environment that we are going to have these conversations in engenders the ability to have these difficult discussions. I'm sure you're right. I'm sure it is a complex issue. It's not just a single issue, but it is an interesting observation, and one I hope that will be the horrible term fleshed out during the work you're going to